Retrospective series and preclinical studies suggest that a hypogonadal state may serve as a risk factor for complications after urethral surgery. To better assess this observation using real-world data, we performed a multi-center retrospective cohort study using data collected from the TriNetX research network between 2008 and 2023. We compare urethroplasty outcomes among cohorts of eugonadal and hypogonadal patients to test two hypotheses. The first is pre-existing hypogonadism associated with inferior surgical outcomes following primary urethroplasty compared to those without pre-existing hypogonadism. And two, among hypogonadal patients, do patients who have received prior testosterone replacement therapy have improved surgical outcomes compared to those that are testosterone replacement naive at the time of their urethroplasty. Propensity-score matching by logistic regression was used to account for baseline differences and pre-existing comorbidities, as well as confounding variables thought to be associated with complications after urethroplasty. The primary outcomes were 5-year revision rates and revision-free survival for endoscopic revision, defined as dilation or DVIU, or redo urethroplasty. We queried 13,000 patients undergoing primary urethroplasty, and after propensity score matching, we compared 477 patients in each cohort. The median age of the cohorts were 55, and the median follow-up time was 5 years. Hypogonadal patients had a statistically significantly higher 5-year redo urethroplasty rate at 11% compared to 6% among eugonadal patients. However, there was no difference in 5-year rates of endoscopic revision at about 11% in both arms. We observed no difference in 5-year revision-free survival time for first endoscopic revision or redo urethroplasty between groups. In our first subgroup analysis, we paradoxically found that hypogonadal patients treated with prior testosterone had a significantly higher 5-year redo urethroplasty rate compared to hypogonadal patients that were testosterone replacement naive. In a second subgroup analysis, we observed that patients in the fourth quartile of preoperative total testosterone, with values less than 50 nanograms per deciliter, had significantly higher rates of redo urethroplasty compared to those in the first, second, and third quartiles, which suggests that a total testosterone greater than 50 nanograms per deciliter may be a useful therapeutic target for urologists. When taken together, results from this large retrospective cohort study suggest that pre-existing hypogonadism may serve as a risk factor for certain adverse urethroplasty outcomes. Nonetheless, increased need for revision surgery that was observed in patients with low preoperative total testosterone was smaller than what has been reported in previously published series. Hypogonadal patients receiving testosterone replacement prior to urethroplasty may represent a higher risk group with regard to the need for redo surgery when compared to hypogonadal patients that are testosterone replacement naive prior to urethroplasty. However, this may be explained by greater stricture complexity or other risk factors not captured in the available data. Ultimately, these findings warrant further analysis and prospectively maintained registries to aid in patient counseling and surgical decision-making.